I forgot to tell you my claim to fame. My claim to fame is that I was once Li Zhu's neighbor. Often the smartest people in the room are the project officers at our funding agencies, because they know things that we don't know. And they know things that we don't know because they hang out with all of us, and we hang out with our own people. And so they know what's going on in all these different places, and they see all these proposals come through. So they know sort of the newest ideas, and they know the best methods. But they also know what they don't have in their portfolio, and what they want in their portfolio. And so if you go to conferences and funders are asked to speak, they're often the most popular speakers in the room, because people want to know what the funding priorities are of the agencies that they represent. So I am hoping that Jason Wolfe and Susannah Allison are in the room. So Susannah Allison is with the National Institute of Mental Health, one of our institutes in our National Institutes of Health system here in the United States. She's a clinical psychologist, and her portfolio involves neurobehavioral and psychosocial studies involving children affected by HIV. And Jason Wolfe is with the USAID Office of HIV and AIDS, and his portfolio works to improve the economic circumstances of families affected by HIV and AIDS. We're going to hear from Dr. Allison first.
Thank you so much for that introduction. I know this is a song that you've heard before, but it is really an honor to be here, and I just want to thank Fred for inviting me and letting me be a part of this amazing day. I mean, the talks have just been spectacular. I have learned a lot. Thanks for that slightly intimidating introduction, because I absolutely feel like I've just learned so much. I mean, I have been exposed to Dr. McKay's work and Dr. Ssewamala and Lucy's but Claude's, but every time I hear them talk, I learn 10 or 12 more things, and so again, it's a real honor to be here. So let's see, do I just start my slides? I don't know if there's a special way to do it.
There's a special man behind the screen.
Aha! Special man behind the screen. Excellent. All right. Well, trying to think my first slide is my very boring government-issued title. And then I think I was just going to talk a little bit about NIH. I know some of you are very familiar with the NIH system, while others of you may not be as familiar. So just to give you a little sense, it's 27 different institutes and centers. So NIMH is just one of 27 different, institutes that funds research for the U.S. government. Aha, there we go. So I was actually going to start with an overview, but overview slides are boring. So here we are with the 27 different institutes and centers. So as you can see, NIMH in the pink is just really one of the institutes at NIH that funds research. So there are other institutes at NIH that do fund work in this area. In fact, a lot of the researchers in the room receive money from NICHD, from NIDA, from NIAID, who are good colleagues of mine who are also very involved and very interested in work in this area. So not only do I work within the NIMH, I work within the Division of AIDS Research at NIMH, so I just wanted to sort of put that out there, because it does, the money that I oversee in the portfolio of grants that I fund does have to be tied to HIV, whether that's in the prevention of HIV infection, or whether that's in research that's really trying to improve the health outcomes of those individuals living with HIV. But those are our two main goals, research goals within the Division of AIDS Research at NIMH. And it includes both basic and clinical neuroscience of HIV infection. Don't ask me too much more about that, because that's probably about where my understanding of the pathophysiology of HIV infection and the central nervous system ends, but we do have a number of talented program officers and scientists who work in that area. And then we also fund basic and applied behavioral and social science to prevent new infections and to limit the morbidity and mortality among those who are infected. And you can see more about our priorities on the website. So, this is another great part about going in the afternoon, is that all of your points have sort of been covered already. So I can say, what's already been said. But what do we know? We know that focusing on individual level factors, whether you're talking about a young woman in Kenya or whether you're talking about a young man in South Chicago, just focusing on individual behaviors does not work alone. You have to take into account, it's not enough. You have to take into account other factors at the community level, at the partnership level, at the societal level that are impacting whether someone becomes HIV infected or whether they engage in care or whether they take their HIV medications. So we've really got a growing body of literature that's really looking at these social determinants. The World Bank, or the World Health Organization, has come out with a lot on social determinants of health. The CDC has come out with a lot on social determinants of health specifically focused on HIV. And I just wanted to include a few here, which again have been brought up already. We're thinking about stigma and discrimination. A big one of the what was it, the bad three, Lucy, in your model, stigma. We know that it really can affect participants' ability to adhere to antiretroviral medications. We know, obviously, economic factors play a big role in both HIV risk as well as in the uptake and HIV incidence and impact on care. And then also legal factors. So what do we know that works? Again, I'm sort of repeating some of what's already been said, but we do know that economic empowerment interventions can reduce levels of depression, improve health, and HIV attitudes among youth based on some of Fred's earlier work. We know that we can, if we reduce barriers to school and provide cash transfers to adolescents, it can delay sexual debut. We've talked a little bit about the World Bank work in Malawi, reducing HIV and HSV2 infections among girls if you provide cash transfers. Also, we haven't really touched on this because it's not an economic strengthening approach, but thinking more about structural interventions, we know that condom social marketing campaigns are also effective in increasing condom use among youth. Most of that work's been done in Cameroon. And also other mass media approaches have also been effective in addressing some of the key risk factors. So now I just wanted to highlight some of these findings that have been funded by from NIMH. This has already been mentioned, but Ashu Handa's work in Kenya, this was funded by an NIMH R01, and to follow up with the cash transfer, Kenya's government cash transfer program there, and which has already been mentioned, found that there was a reduction in sexual debut. However, there was no impact on condom use or number of partners or transactional sex. So I just think it's really interesting when we talk about kind of future steps, and we think about, I guess there's 2 points related to this. We may implement the same intervention in different contexts and have different outcomes. We may have different impacts on outcomes because we're dealing in a different context, right? So if you're implementing something in Malawi, the drivers of HIV risk may be very different than the drivers in in rural Ethiopia. So it's really important to sort of understand that and understand that while we may not have the same impacts on outcomes, we really need to think about the context within which that trial was delivered. And I forget what my other point was. All right. This is some work that's being done in rural Kenya, and it's instead of providing cash transfers to families, what they're trying to do is really reduce the barriers to school enrollment for youth who have been orphaned. And the way they're doing that is that they are providing school fees and uniforms, and also providing a community visitor. And Dr. Cho and Dr. Halfors have found some promising preliminary findings from pilot work there. I'm going to talk about an ongoing larger trial to look at this type of an approach. But again, sort of have found some positive impacts on sexual risk, as well as school outcomes that you would expect. And then this just talks a little bit more about Fred's work. So now I just wanted to highlight a little bit of some ongoing trials that NIMH is funding in this area, just to sort of give you an idea of what's in the pipeline. So this is a large randomized control trial in rural South Africa, which is being carried out by Audrey Pettifor from the University of North Carolina. And this trial is looking at the impact of a conditional cash transfer on young women, and is following them for up to 3 years, looking at both HIV and HSV2 as outcomes. This is the cash is conditional on school attendance. And it's actually, this is a multi-level intervention. So not only are girls randomized at the individual level to either the, receiving the cash transfers or not, communities are also randomized to receive a community mobilization intervention. And the community mobilization is really focused on young men, 18 to 35. And the goal there is to really sort of question social norms and really push men to take care of younger women in their communities, with the idea being to reduce the amount of sex that's happening between younger girls and older men, and also try to change some gender norms in those communities. So it's going to be great to be able to see, because half of the villages will have received this community mobilization intervention. So it'll be this will be a sort of a factorial design, and we'll really be able to pull those apart. So this is ongoing. There's Audrey and her team has enrolled over 2,500 young women and are currently following them. So this is an interesting study. This is some work by Lisa Butler in Kenya. And what she's doing is she received a 2-year R21 to look at the child outcomes of an intervention, an agricultural economic intervention that's targeting adults who are living with HIV. So what the adult trial is looking at is whether a agricultural intervention, so they're provided with a foot-operated irrigation pump, a microeconomic loan, and training in sustainable farming. And they're looking at whether the provision of this intervention improves the outcomes among individuals who are adults who are living with HIV. Now, what Lisa did is she applied for another grant to then go into those families and at the same time look at the outcomes on the young children within those families. And they've finished collecting all the data. They collected data on almost 200 young children. And she's analyzing the data as we speak, but she said that I was allowed to say that they've really found some promising results. So stay tuned for more from Dr. Butler. And I think this is my last slide in terms of ongoing work, but this is to follow up from that pilot project that I was talking about that's happening in Kenya. This is a larger trial to, again, look at whether we take away those barriers to school retention for orphan children in Kenya, do we find impacts then on health outcomes, specifically on HIV incidence and on HSV2? What this will also allow is to look at some of these potential mediators and the role of gender. And also, they're also going to be conducting some cost-effectiveness analyses. So I thought I'd talk a little bit about our research priorities. So as you can see, NIMH does have a subset of grants that do focus on economic strengthening within a larger subset of grants that are really looking at structural level interventions to both curb new infections and improve outcomes among those who are living with HIV. So I thought I'd just include a more general slide on our research priorities, and that's really looking at multi-level structural interventions that can intervene upon some of these social determinants that I mentioned earlier: stigma, violence in communities, some of the legal factors that may be influencing risk. So what are some of the multi-level kinds of interventions that could minimize the negative effects of these social determinants? And then thinking about, and then really understanding, I think, the mechanisms by which our interventions are impacting on health outcomes. I think, as many people have mentioned, we found positive impacts for cash transfer interventions, but the actual mechanisms of action aren't as clear. And I think to really understand that could strengthen our ability to scale them up. And then I wanted to include a few adolescent-specific research priorities, really understanding sort of the influence of gender-based violence and HIV risk and care among adolescents, and thinking about structural level interventions to address this relationship. This is actually the relationship between gender-based violence and HIV is a significant priority for the White House. There's been a number of meetings on this very topic area, and some papers that have been pulled out, and meetings. And anyway, I'm happy to send you all information on that. So we'd love to be able to fund more work in this area. I think also looking at availability, accessibility, and acceptability of HIV testing and treatment and condoms and male circumcision among adolescents. These are all, obviously critically important to being able to address the HIV epidemic among adolescents. And then thinking about more around structural level interventions for youth that are living with HIV, which we've heard a little bit more about. Some of Fred's ongoing work is thinking more about economic strengthening approaches for youth who are living with HIV. And then for my neuroscience colleagues, they asked me to include a bullet on sort of understanding how HIV infection impacts functional abilities and skills, and how those challenges might impact the uptake and efficacy of economic strengthening approaches. So I just wanted to finish off with some slides that include links to some of our current program announcements. So program announcements are a way for the NIH to articulate our priorities to you. There's no set aside funds that are associated with program announcements, but what they do is they lay out our priority areas. And we recently issued a number of new program announcements within our division. So I've included links to them here. And I wanted to lead off with really the first one, which is advancing structural level interventions through enhanced understanding of social determinants in HIV prevention and care. And so you can see from that there's sort of two main thrusts, which are sort of really trying to understand the impact of social determinants on key HIV outcomes, as well as trying to think about how do we intervene on a structural level to sort of affect those relationships, reduce them. We also have an R34 program announcement, which is a 3-year sort of clinical trial planning grant. It's very popular, and we're able to fund a number of really innovative ideas through the R34 mechanism that then you can collect data, pilot data, that would then allow you to go on to apply for a larger R01 trial. And then thinking about the HIV care continuum. And then let's see, what else? Anyway, so these are some more as well, which I think the slides will be circulated so you can see some of the different program announcements. But just to highlight on this slide, thinking a lot about adherence to both HIV medications, but also to care. I think we heard a lot about how youth not only struggle with taking medications, but also remaining engaged in care. And we know that that's also a really important part of remaining healthy. It's not just taking your medications, but going back to the doctor and staying engaged in care. There's also a program announcement out around the ethical issues in research on HIV, which I think it's out of NIAID, actually. They have a bioethicist, and they're growing this program. And I think there's a lot of really interesting questions that come up with doing this work, whether that's in methodology, that came up already at this meeting, whether that's in informed consent or working with adolescents, the legal, the family implications, disclosure. We know disclosure rates are really low to adolescents who are infected with HIV. So how do we do research that is, how do we enroll a representative sample of HIV positive youth if only 20% of them actually know their HIV status? So I think there are a lot of great questions that could be answered through this program announcement. And then there's another PA around stigma to improving health. And these are some of the more neuroscience program announcements that I wanted to share with you. And that's it.
Okay, so a more humanistic version of a capitalist view of development. Anybody else? Okay, what are some examples of interventions or supports that we might provide under this broad category of economic strengthening? Maybe that's an easier starting point. Cash transfers, savings programs. Coping with economic vulnerabilities and shocks. That sounds really good. What else? What are some other examples? We've heard lots of examples today, throughout the day. Training? Training on what? Financial literacy, vocational training, job training, workforce training. So self-employment, jobs, entrepreneurship, all sorts of things. So I have to say economic strengthening was like a brand new term for me when I started engaging with the PEPFAR program at USAID. Where in the work that I come from, we call things, microenterprise development. We talk about financial services. We might talk about financial inclusion. We've got all sorts of different wonky little terms for things that we do. But economic strengthening was like a brand new thing for me. I didn't know what the heck PEPFAR was really talking about when they referred to economic strengthening. So I was really looking forward to understanding what they meant by this. I figured this is a giant program spending lots and lots of money. They must have a very clear idea of what they mean by this. And as I started talking to people, this is what I was getting. I was just getting examples of lots of different types of interventions. And they're pretty diverse types of interventions as well. There was not necessarily a whole lot of unifying elements throughout this. And I thought, okay, now I understand. They really have no idea what they're talking about. That's good to know. It's a good starting point. and at least now I know where we are starting from. And I spent a lot of time trying to make sense of all of this. Because these were all things that, I mean, since the beginning of PEPFAR, we have invested in one way or another, with oftentimes really disappointing or lackluster results, and sometimes really happy, positive results for the things that they value. But recognizing that they're doing this in an uncertain and risky world. That's probably not a particularly helpful operational or academic definition, but it was helpful for me. It was a humanistic definition, I guess, in terms of understanding from a beneficiary perspective, from a household perspective, from an individual perspective, what this might mean. And so that has, I am neglecting to give you the stale policy definition that we use in PEPFAR, but I can certainly share that with you if you like. But I thought it was maybe helpful to start off things by recognizing that, at least from our perspective in PEPFAR, this is what we're trying to achieve with economic strengthening. So getting into this idea of research gaps or knowledge gaps or whatever that I see us facing in the PEPFAR program to try to do better with the resources we have. Is first of all recognizing that oftentimes when I read papers, when I go to conferences, when I'm talking with folks, this is kind of the discourse that I hear. There's some interventions under this category of economic strengthening, and we've got some, child or adolescent related outcomes, usually around health or education or psychosocial well-being or something like that, and there's some sort of association between the two. And many times that's kind of the conclusion. We found this correlation, we found these associations, and that's great, right? And it is great. And I'm really happy that people have looked into this. But I'm finding now within the PEPFAR program, by and large, across the board, whether you're an epidemiologist or a medical doctor, whether you work on treatment or prevention or OVC programs, there is a broad acceptance that poverty and socioeconomic status is a big problem for the outcomes that we're trying to achieve. But there's a lot that we don't know about how this relationship comes about and how we affect this relationship. So for instance, who do we work with? This has been a big challenge, a big crusade of mine, I guess I would say, since I started working with the PEPFAR program. When we're addressing socioeconomic vulnerabilities, economic vulnerabilities. Let's even take the social part out of it. Economic vulnerabilities, as someone mentioned in the beginning. The population we're working with is very diverse. Not everybody is the same. It's not very homogeneous in terms of economic vulnerabilities. There are subgroups. I think Lucy referred to this in her talk. Subgroups of people that we're working with who may need different things or may respond to interventions in very different ways. And it's very helpful if we can do a better job of understanding who those subgroups are, segmenting the beneficiary population we're trying to work with, and better tailor our interventions to their needs. But we don't oftentimes do that, or if we do, it's not based on economic criteria or economic characteristics. It's based on more social or health-related kinds of characteristics. For instance, in the OVC programming, which is the area that I work mostly in, there's a lot of segmentation depending on whether you're an orphan or whether you're not. But that doesn't necessarily imply specific economic characteristics. There's still a lot of diversity there. So who exactly are we working with? So that's the segmentation part of it. But also, who are we working with? Are we working with households? Are we working with families? Are we working with young people themselves? Are we working with, if we're working with a household, are we working with the head of household? Or are we working with a female caregiver? There are a lot of implications there in terms of who actually has control of resources. And if we're actually able to affect some changes there with the people we're working with, are they actually the decision makers in how those resources get used? How and why do these people, whoever it is that we're working with, get involved in the interventions that we're offering? And for me, this is a really key issue because in a lot of economic strengthening and livelihoods approaches, there is a very important principle of self-selection, that people get involved in these interventions or in these activities because they find value for it in themselves and they choose to do it. Because we have lots of examples of where we sort of force people. Force is a harsh word. We strongly suggest that people participate in certain interventions, and they may lack a lot of kind of ownership or buy-in into the intervention itself, and the intervention just doesn't work as well when they haven't chosen it for themselves. So self-selection is really, really important. And to what extent are these principles of self-selection coming into play in terms of the beneficiaries that we're trying to work with getting involved in the interventions that we're offering? What else do they get in addition to this economic strengthening intervention, whatever it happens to be? A lot of the research nowadays, and certainly a lot of the experience on the ground, seems to show that economic strengthening is really important. It's necessary to achieve a lot of outcomes, but it's likely insufficient by itself. There are other things that are required. Lucy's example of cash plus care, I think, is very demonstrative of this. But what are those other things that they may get or that they may need? And what does this economic strengthening intervention achieve by itself? Sort of the direct outcomes of participation in the economic strengthening intervention. Is it some sort of economic empowerment, which is a really loosey-goosey term, but are people saving more? Do they have access to more resources? Do they have higher income? Do they have smoother consumption? Or is it really an incentive? And Lucy, I think, made this point, again, very well in her presentation in talking about some of the recent work done around cash transfers for HIV prevention outcomes, where the cash transfer was intended more as an incentive to engage in a certain behavior rather than to actually bring about some economic effect at the household or participant level. And then how do whatever those outcomes are relate to the outcomes we actually care about in terms of child or youth well-being, the social or health outcomes? What are the mediators and moderators of those relationships? And so for me, those are basically the knowledge gaps that we collectively have yet to dig into. One thing I want to So two other things that I wanted to sort of point out is that the way I see it, there are sort of, at least in the context of PEPFAR programs, there are sort of two giant types of causal pathways that I see our programs potentially engaging in. One is, and this is very prevalent in our OVC programs, particularly our OVC programs that are focusing on sort of primary school age kids as opposed to adolescents, where we're doing some sort of economic strengthening intervention with a family, with the head of household, intending to have some effect on the purchasing power of that household, either to help them to be able to purchase more things, to improve consumption in the household, to smooth consumption, improve money management, to increase overall income, whatever. And then when that happens, the family is now able to better invest in the child. And in sort of three general areas is where our programs seem to be looking, in terms of food security, in terms of health, and in terms of education. And I'll say, based on the evidence that we have to date, that, and we all can always use more, but the connection to food security seems to be a pretty well-documented outcome from this whole pathway. But health and education, not at all. Oftentimes it's not measured, and even sometimes when it is measured, it's just inconclusive whether there has been an effect there. So those are outcomes in this type of pathway that definitely need to be better investigated. But some other research gaps in this is that, number one, this assumes that there are, that we understand what the spending patterns currently are or should be for an economically empowered household in this particular context, and oftentimes we actually don't know it. I talked to some of our partners on the ground, and they actually have a not very well developed understanding of what it costs to send a child to school, what it costs to access health care in this particular context. And it's really difficult to come up with a good understanding of what the program should be achieving when you don't even understand that aspect of the context very well. Intra-household decision-making. Again, this is a model of affecting some sort of change at the family level and then hoping that that results in better investment in children. But intra-household decision-making is something that we don't have a really good understanding of, I think, most anywhere. But even in this context, we're assuming it's going to happen well, and oftentimes it's just not something that is being looked at. Supply side factors are huge for health and education. It's hard to have good impacts there if there aren't schools or there aren't clinics or the quality of the services they're providing aren't good enough that parents actually want to send their children there. And that's something that's oftentimes out of the control of our programs. Sometimes not, but certainly for those of you engaged in research, trying to figure out how you're going to take those factors into account is a big challenge. I have no idea how you do that, but that's why you guys are the experts. I assume you'll figure it out somehow. And then a big thing is the observation period. I would say both exposure and observation period. A lot of the sort of recent evaluations or research that has happened within PEPFAR has been through in a very short time period, relatively speaking, 12 months, 18 months, something like that. And you have to wonder whether some of the outcomes we're looking for just might take longer than that. So if we're not seeing the kinds of outcomes we're hoping to see after 12 months, is it because the intervention didn't work or because we didn't give it long enough? And this is sort of the other pathway, I think especially for adolescents, where it's a much more complicated pathway. And here it's where we may be working with the family, but we may also be working with the adolescent directly. And recognizing that the family has some influence over outcomes, but the adolescents themselves also have influence over some outcomes. And it's really complicated. I see a lot of our programs choosing sort of one or the other. They'll work with the family or with the adolescent, but rarely with both. And I think that may be a shortcoming based on some of the research, at least that I'm familiar with. I know the Zomba pilot in Malawi has been mentioned a couple times by Mike and by Lucy in their presentations. And for me, I think it's a brilliant piece of research in terms of the research design. And one of, at least in my community, so many people have obsessed over the HIV end lines of that study and whether it was done well and what we can conclude from it and so on and so forth, and have, in my opinion, glossed over some of the really interesting stuff in that study, which was looking at doing a cash transfer in different sort of permutations, but always with the family receiving part, the parents, the caregivers receiving part, and the adolescent girl herself receiving part of the cash transfer. It was recognizing that the family has an influence over the outcomes they were looking for, and the girl herself also has an influence over it. And they were able to draw some really, I think, interesting inferences from that. And I don't hear that talked about very much, and I don't see many programs or researchers really following up on that. But I think it's a quite important thing. And some of the same sort of knowledge gaps come into play there. Lastly, I want to conclude with some other kind of bigger picture questions. In the PEPFAR program, economic strengthening is everywhere in terms of what we're doing, but it is largely a platform for the work we do around impact mitigation for HIV, particularly for OVC support. But we really are interested to know, is this platform also effective for prevention outcomes as a structural intervention? And then lastly, best to identify and segment our beneficiaries, what's the optimal exposure period for the outcomes we're looking for, and very importantly, how do we scale up and sustain or exit from these interventions? So everything in the kitchen sink there. I hope this has been helpful to get a conversation going on a lot of these issues, and thank you.
Fred, we're behind. What's your preference?
We have some time for questions. Maybe quick questions.
Sorry, I'm talking too much. Jason, this is really fantastic, and it wasn't, and was lots of really new, important thoughts and ideas. What strikes me is that we've got a situation here where we need to know what to do. We need to know a lot of very unglamorous nuts and bolts questions. Where does the intervention need to go to? Who should it go to? How long does it need to last? How long do we need to test it for? When's its outcomes? What are the mechanisms of these different outcomes? Do you have any thoughts about what the research community could do, as a community rather than as a set of individuals, to try and provide that body of evidence that's needed as fast as possible? I mean, I've seen it happen in other fields, but often it's taken 30 years for everyone to get their act together and start using, the same outcome measures, or to start working in a more concerted way. From a slightly out of the, in the world of universities and trying to get NIH grants perspective, what do you think we could do?
Wow. So I guess, just very simplistically, we know that, we're talking about cross-sectoral research here. Absolutely. We're talking about, economic interventions with economic outcomes that lead, hopefully, if we do both kind of sides or all sides engaged in this. What I've seen just in my own work is that, say you have a psychologist who's a PI on a project. I don't mean to pick on psychologists. That's just what came to my mind. Pick anything. Pick a social worker. Pick whatever. And they will know very well the measures, the scales, the so forth in their discipline that you use, that you don't use, that there's debate over, and they will have opinions on it. And then when it comes to the economic interventions and economic outcomes, they just assume, well, that's been settled. It's just this one thing that I saw in the last study, and that's what I pick up and use, without giving a lot of thought into it, or consulting with others who may know more about that particular discipline than they do. So, this type of dialogue, I think, is really required. But also, just the folks on the economic side kind of need to get their act together and say, here are the measures, the outcomes that we think are best to use, to suggest to our colleagues across the aisle or across the campus, across the quad, who are doing research that touches on our discipline. And I don't know that, speaking for, I'm taking that as my community, that we've done a good job on that in terms of pulling that stuff together or making those kinds of recommendations. But I don't know if that's helpful. I think there's a lot of work to be done, and I think a lot of it just involves people talking to each other who don't normally, I guess, engage with each other.
No, and I think, as a U.S. government agency, we need to do a better job at talking to each other as well. We don't. We all, work in the same city, but we don't spend as much time talking to each other about, what are the PEP, what's PEPFAR struggling to fund, where are their decision points, and how can the work that we fund really help them inform the programs that they're supporting. And I think things have gotten better since PEPFAR started, and I've been working at NIH. In fact, I was on a call Monday about this very topic area. So they're happening. The wheels of government, unfortunately, are slow, but there is a lot of interest, and I do think things are happening to help to answer the questions that you're talking about. I think that there are so many. There's so much data, right, that's been collected that could help us to answer these questions, or ongoing research where questions could be added to help answer some of these questions. So do we need to launch another, 5-year study, many millions of dollars? Or can we go and leverage existing ongoing work to answer these questions? And I think it's the latter. And there are mechanisms to do that at NIH as well. You don't have to, there's grants in my portfolio that are not collecting new data. They're analyzing data that already exists. They're combining data sets. They're working with, like, Dr. Handa, right? He was going in and doing another wave of data collection onto work that had already been carried out by UNICEF and by the Kenyan government. So I think there's ways of answering these questions, leveraging investments that others have already made.